Okay. It's sharing.
They have been unmuted.
Good afternoon. Can you hear me? Good afternoon.
Yes,
can you hear me?
Yes, we cannot hear you.
Good afternoon, everybody. You're welcome to this webinar. We're talking about elevating the ptotic lead with a sling, and I'll start, and my esteemed colleague, Dr. Akang, will take off from where I leave off. First of all, we have a poll question. I'd like you to answer this. What percentage of your surgeries, either performed or assisted, are ptosis surgeries? Okay. So let's continue.
Okay, this is the result.
Okay. So we can see that about 73% of people have ptosis surgeries, making up about less than 5% of all the surgeries that they either perform or assist. And for those that, just about 9% have it, making up 11 to 50%. Okay, thank you very much. By way of definition, ptosis actually refers to abnormal droop of any part, any organ or part of an organ. So when we say blepharoptosis, what we actually refer to is specifically abnormal droop of the lids, usually the upper lid, but we just use it regularly as the word ptosis. A sling refers to any flexible strap used as a loop to support or to raise any hanging weight. And in this context, we're referring to a contraction which links the tarsus with the frontalis muscle. This is just a picture diagram to highlight ptosis and a normal eye. And this to remind us of the support of the lid to the bony orbit. You can see the tendon of the levator palpebrae superioris as it attaches to the upper border of the tarsus, and the ligaments, the palpebral ligaments that anchor the lid to the lateral and medial aspects of the bony orbit. And this just to let us know, see an overview cross-section of the frontalis muscle, the frontalis part of it, how it's oriented to the anterior part of the eyelid. Okay, and the principle of the frontalis is simple. It just creates a link between the frontalis muscle and the tarsus, the upper tarsus, and that creates another vector to the eyelid, thereby achieving elevation of the drooping lid. And this is a cross section. And here we can appreciate the tarsus of the upper lid. This is the orbital septum. And what a sling does is to just create a connection between the frontalis muscle and the upper tarsus here. Okay. So what's the aim? The aim of a sling is to achieve a clear visual axis. And for a young child, to help to prevent amblyopia, it will enhance cosmesis by providing an upper lid crease, which many times in these children is absent, and achieve symmetry with the other eye. When do we do a frontalis sling? It is often done. The major indication is for when you have poor levator muscle function, and that's assessed by levator muscle function that is 4 millimeters or less. And there are several conditions which are characterized by poor levator function. This just represents some. For example, in simple congenital ptosis, which is about the most common, and in trauma, which might be birth trauma or acquired trauma. In blepharophimosis epicanthus syndrome, you have ptosis with poor levator function. Chronic progressive external ophthalmoplegia and myotonic dystrophies are conditions in which you have this, and they're associated with other ophthalmic or systemic conditions. And the evaluation, the main aim of the evaluation is to help you to decide when you're assessing a ptosis patient, what kind of surgery are you going to do? And that's where your levator function will help you. How much surgery for other ptosis surgery? This will also help you to assess how much surgery you are going to do. But in these patients for frontalis sling, the levator function is back up by the MRD and the lead crease will help you to assess what kind of surgery you will do. Then you want to assess what is the risk of exposure in this patient, and that's why your Bell's testing to assess lagophthalmos and your Schimmel's test. You want to, if you have a patient who might need a levator frontalis sling, and you have a patient who has a risk, maybe he has poor Bell's phenomenon, he has lagophthalmos, or the Schimmel's test shows a reduction from normal, you will know that this patient, you have to do a lift just above the visual axis so that you prevent exposure. You will now reduce the risk of his having the frequency of using artificial tears while achieving a lead lift above the visual axis and preventing the risk of exposure post-operatively. And in other things you want to also rule out in your evaluation, like I mentioned, some conditions are associated with the systemic ocular conditions. So phenylephrine response to, of course, to rule out corneas and fundoscopy. You know, you want to assess other associated conditions which may be associated with, for example, pigmented retinopathy, as you may see in CPU. So this is what your evaluation helps you to do. This is a schema to assess measurement of your MRD and helps you knowing fully well that your normal upper lid just covers 2 millimeters of your limbus. So that means that when you have your, for example, you have your upper lid at the visual axis, that you know that your MRD is 0. Can you please mute that? So other considerations you want to do in your evaluation, you know, you want to find out there are other associated conditions. For example, we mentioned that poor levator function is associated with ptosis of various kinds. We're associated with other ocular features or systemic features. And some of them will need other additional surgeries in addition to the frontalis sling. So this is what your evaluation will help you to do. For example, presence of Marcus gun jaw winking. You know, it's associated with, might be associated with poor levator function. And if you just do a frontalis sling, you will not have achieved the solution you want. So these are the things you consider in evaluating the patient. Is there presence of, like we mentioned before, blepharophimosis, Picantus syndrome? Is there presence of amblyopia? Because to determine, you might do the frontalis sling. However, you might want to now intervene earlier for this patient. Presence of Horner syndrome or Duane's, as the case may be. So timing of surgery, when would you operate? Okay, we're looking at severity, you know. For example, for children, you are going to have to tie up. The gold standard, usually most people agreed, is using the facial Lata. But if a child has a mild ptosis and the visual axis is covered, is not compromised, and there's no really threat for amblyopia at that age, you may want, and ptosis is mild, you may want to observe. However, you also want to think if there's a possible threat for amblyopia, visual axis is to be covered, the child has a head tilt, or the child has a chin up position. At that point in time, you want to lift up the lid as urgently as possible. And then you are thinking of what kind of materials you want to do. Maybe the patient, for example, typically patient has blepharophimosis, for example. You know that ptosis is not the only component of that condition. You have other things you have to do, but you have to deal with the possible amblyopia at that point. So you want to do a temporary procedure. So you might need, that's where you call in the need for temporary materials, knowing fully well that you have to reverse what you do and deal with other components of the condition, like the picantus and telecanthus and all that, you know. For when, sometimes you will have to, like I said, the definitive procedure for most patients is using facial Lata. However, you can't do facial Lata if a child is less than 3 to 5 years old, but you want to deal with the condition. So you have to now decide, oh, are we going to wait for the child to be older while we do something temporary? So that the things you consider, what are other psychosocial issues? A child 3 to 5 years old is going to preschool. We really want to deal with the cosmetic issues and psychological issues that will come with having a child that looks a little different. So those are things you consider. Availability of the materials that you have. What about the patient who comes in post-trauma? You know, an adult with trauma, third nerve palsy. You might not want to operate immediately. You want to wait usually for about 3 to 6 months and watch for maybe spontaneous resolution. So these are all the things you tie up together to determine when best you will intervene. So talking back to the frontalis sling, it dates back to the early 90s where it was introduced, and over the years it has undergone various modifications, and the various modifications of the process, you know, give testament to all this, from the single triangle, which can be done as an urgent procedure for just to deal with amblyopia to be reversed for later, so up to the single pentagon, which is still in use now, or the double pentagon. These are various modifications that it has undergone over the years. So what are we talking about? The ideal sling. What is the ideal sling material? You know, these are the qualities that we're looking for, and these are the qualities that have been sought for over the years that will make us to now use different materials. We're all looking for these qualities in these different materials. The ideal sling material has to be effective to give upper lid lift. It has to give a good lift. It has to give a good contour. It has to give symmetry. It has to be useful in kids. You have to be able to use it in kids. And it has to have few complications. We're going to talk about that shortly. It has to be readily available, and it has to be placed easily. And if for any reason you have to adjust it, you have to be able to adjust it easily, or maybe even remove it. It has to be amenable to such, and it has to be inexpensive. So the question now is, does an ideal sling exist? It's an attempt to answer this. That's where all the different materials have come into play. So we have the autogenous materials, Fascia Lata, Palmaris longus, and Temporalis Fascia. Of these three, the least difficult to harvest, the least, is still Fascia Lata, you know, and you have the allogenic material, which is the banked Fascia Lata. The synthetic materials, the plethora of them, lend testament to the fact that we're looking for so many, trying to obviate the drawbacks of the other existing materials. For example, some of them are suture materials like proline, even silk, nylon, they have been used. Some of them have better, higher risk of recurrence. You know, of all the synthetic materials, the prototype still remains silicone, which is very, it's quite effective. It has good elastic properties and you're able to achieve good lift. You're able to achieve good contour, and it's especially useful for those conditions in which there might be risk of exposure. It has good elastic properties. However, the drawbacks for some of this still remains recurrence because of the fact that many of them do not integrate into tissue. So there's still slippage of material, unlike what you have for the autogenous materials, where they have integration and into fibrovascular tissue. This does not. So you might still be able to take these ones out without actually adhesion to the underlying tissues. However, that drawback will now lead to recurrence of ptosis in many of these materials. This is just to show a schema of the surface marking of the thigh, to show how the fascia lata is harvested. Fascia lata actually refers to the condensation of fascia over the quadriceps muscle. So just the surface marking is a line drawn from the anterior superior iliac spine to the lateral tibial condyle, just about 2 millimeters above the knee joint, and a facial stripper is used to harvest it. That's actually another surgery, and that's a drawback, you know. And this is the material got about 2 millimeter wide strips, 2 centimeter wide strips are taken and used. It's extremely slippery. This autogenous fascia lata is still described as the gold standard today, and it's one of all the autogenous materials, the most common. It has low soft tissue complications. What do we mean by soft tissue complications? Extrusion, infection, granuloma formation. There's a low risk of that in use of autogenous fascia lata. However, the drawback, you have to have a second operation site. So you have an operation site on the upper outer aspect of the thigh. Yes, and this possibility of that site having a donor site complication like scarring and all that, which is a cosmetic blemish. And if the success are achieved from the fact that there's resorption and integration into tissue. Another drawback is that you cannot use fascia lata for young children. The minimum patient height of 34 inches have to be achieved for you to be able to have good length of fascia lata. So that's the age for about a 4 to 5 year old child. So what would you do for a child who has ptosis and he comes and is 3 years old and is 2.5 years old? You know, because you know at that point in time you can't get autogenous fascia lata. And for children, even with that, the harvest is still small. And in fact, there's a for some people find technical difficulties in harvesting fascia lata. And in some environments, you don't even have a facial stripper. So the availability is not there. The technical know-how might not be there available to use it. So that's one drawback for it. So that's why we come to the banked fascia lata. And this is especially good for children, you know, where they don't have adequate amount of their autogenous fascia lata. You know, it's effective in achieving lift, symmetry, as we talked about earlier, especially in the short term. And it tends to be replaced by fibrous tissue, and that's what helps the permanence. However, in a few cases, you might actually have it absorbed prematurely. So you still have slipping and recurrence. And in fact, some studies have found out that the effective ptosis resolution with bank facial lata tends to drop after a couple of years significantly, you know, and if there's any need for revision, fibrous tissue will hinder it. And a very important drawback of bank facial lata is the risk of disease transmission. So that's why synthetics have come into play. This is just a picture of silicone, and the prototype for the synthetics are silicone. It's readily available. You don't have donor site issue because there's no second surgery, and there's no risk of cross-infection. It's easily adjustable, and if silicone is especially elastic, and it's reversible if you have to do that. For example, for some conditions, you have to do as a temporary procedure. It's reversible, and it's very good, easily done for children. However, the downside of it is soft tissue complications, which is higher than using the autogenous material, infection, extrusion, granuloma. However, some other materials have come up, just like Gore-Tex, polytetrafluoroethylene, which have tried to deal with these issues of recurrence and soft tissue materials, soft tissue complications. But generally, the downside of synthetic is that they tend to have more of this than the autogenous materials, slippage and recurrence. So other considerations I would look for this patient. Haven't dealt with the material for the surgery. What about the anesthesia? You know, what kind of anesthesia would you want to use? Because you want as much as possible to look at what you would do to adjust, enhance adjustment on the table. For children, usually you have to do general anesthesia. However, for adults, the adult may come in with ptosis, maybe post-trauma and all that, and you have to do a sling. You want to think of other forms of anesthesia, like regional anesthesia, infiltration. What about additional surgeries that you might want to do? Marcus Gunn jaw winking, where you will have to think of the options. There are so many varied schools of thought. Oh, you operate bilaterally, which many patients will not like because you're going to touch the normal eye, you know. But by and large, most people have finally settled for the fact that you do a levator extirpation, as in you remove the levator muscle and you do a secondary sling. So you are going to do it in addition to that. So those are things you will consider for this patient. Like I also mentioned earlier, in a blepharophimosis syndrome. Oh yes, you do a sling, but you are going to do a sling either as a stage surgery with a cantoplasty, with a telecanthus repair, or as it is done now as a one-stage procedure. So the sling just forms one of several surgeries that you are doing at home. But these are worth considering, and these are things that you have to explain in counseling to the patient, you know, and watching those things in follow-up. For example, possibly postoperative complications and what you should expect and all that. So those are the things that you have to put into consideration when you are preparing the patient for surgery. So let's talk about the procedure. This is the first pentagon. There are 5 suture marks. So this medial lower tarsal incision, these are just skin stab incisions. And this is done at the level of the medial corneal limbus, and these are the lateral corneal limbus, about 3 millimeters from the pupilla, from the lid margin. This second stab is in line with the inner medial canthus, and the lateral upper is in line with the lateral canthus. While these are also stab incisions. While this is actually a deep incision, which you make with a pocket. It's important to make a deep pocket because this is where you are going to finally attach your sling, whichever method you use, whether you're using silicone or you're using a bank facial lata. Okay, so this is about 10 millimeters from the upper lid margin. And it's a deep incision with a pocket that is created. And this is the sling being passed, either using a right needle or even a simple strong needle holder, depending on what you have available for you. Okay. So now let's go back to, you can see when you are passing through here, this root, I forgot to mention that this root from here to here is suborbicularis, and this root from here to here is epitarsal. Okay, and it's very important to make sure that when you take the epitarsal root, you evert the lid to be sure that you do not breach the tarsal plate. Otherwise, your cornea will be in trouble. Okay, and this is what you do. You finally come out at the head of the pentagon, and this is your final knot. That's the pentagon, Fox pentagon method, and this is the Crawford method. These are just the two I wanted to just highlight. Okay. Still, this is the medial corneal limbus, lateral corneal limbus, central, and the 10 millimeter above. The bottom lines, you still come out at the head of the apex and achieve good knots. Now, it's so important what you do at the knot. That's why I wanted to highlight here. Now, this is the silicone sleeve. This is silicone rod, and it comes with a sleeve. There are two methods that you can use to achieve good knot care. Now, this is here you pass both ends of the silicone through the sleeve and achieve. Some people will put a 6/0 vicryl suture here and achieve a good knot to avoid slippage and bury it into the tunnel that you have already created here. It's so important to achieve that. Or one suture, one end of the silicone is coming from here, another end from here. So you simply pass it in opposite directions and create a knot, which you may still, some people will still put a 6/0 vicryl suture there and bury it. Okay, this is the head of the pentagon. So your 5 sutures, your 5 knots, you would have to put a suture here, and these other ones are you put a stitch here, and the one over the tassels is just skin crease, so you will not need to put anything there. This is a frost suture that is put to protect the cornea. This is just the open approach. One of the complications we talked about was recurrence, and because the slippage of the suture, the sling material. So one of the approaches that I use now is to actually suture the sling material onto the surface of the cornea. So that's another method. But yeah, you have an lid crease incision which is closed appropriately. The complications we'll talk about. I just want to emphasize lag of thermals. This is something that you almost universally expected. So you have to prepare the patient beforehand and let him know, because it's quite alarming for somebody to say, oh, my child was sleeping and the eye couldn't close well. However, it tends to improve over time. I just want to emphasize corneal abrasion. This is not, it just shows that you actually did not put your frost suture well, and you didn't cover your cornea well, and maybe it's when the dressing was put over, especially with lag of thermals, and you have this, it's actually preventable. This is another soft tissue complication. This is an extrusion of the sling material, this granuloma, and this is the corneal abrasion. So in conclusion, appropriately selecting your patient, evaluating your patient, and noting associated clinical features which will influence the possible additional surgery and other surgical techniques is so important, and anticipating the complications and mitigating against them will help us to have a good outcome for these patients. Thank you so much. And Dr. Akan will take the next presentation. Thank you. Okay. Continue. You continue, sir. Sir, may continue. I'm no longer sharing.
Can you hear me? Hello, can you hear me?
Yes, we can.
Okay, thank you very much. I want to send my greetings to my teachers, my colleagues, and resident doctors. God bless you. My colleague, Dr. Allen, has done a good job. Mine is just to put in 1 or 2 words here and there. So let's, maybe a word on COVID, just to let us know that in every cloud, like people would say, there's a silver lining. The clouds may be dark today, but we know that there's a silver lining somewhere. The issue of COVID has made me to think inwards and upwards. And I believe that all of us have had time to think about it too. So let's take off from there. By way of introduction, ptosis is probably one of the most common oculoplastic cases one encounters from time to time. Every ophthalmologist would wish to do something about it, but one begins to grapple with some distressing thoughts. You begin to think, are you doing the right thing? What type of surgery would be appropriate? What if I run into complications? It can be hidden. It's on the face. Everybody will see it. I have the issue of running into, maybe it could be a free advert for the wrong reason. They are being advertised all over the world because everybody will see it. So what do I do? Do I refer or do I do whatever I can? Those are the questions.
So attendees are requesting for slideshow.
Okay. Thank you very much. So online teaching generation gap, you've just got to break it. You can see experience doesn't come easy, but there's a generation gap. There's something we need to bridge here. IT, infotech. And I would just want to use this opportunity to thank the CMD of the National Eye Center, because the young man that helped to put this together is our vibrant resident, Dr. Bature. Very, very humble. We want to thank him. Dr. Bature, if you are there listening, look at that. We must do something about this. Hello. All right, let's go on. M is to recreate as nearly perfect an anatomic result as possible by elevating the position of the lid or lids and creating a lid fold if necessary. And there's always a need for that. You look at the contour and the symmetry of the lids, it's very, very vital. Some clinical pills, sling placement over the surface of the tarsal plate. And I do this because my colleague had already done a lot of work showing so many things. So this should be just to add one or two things. Can cause evasion, varying degrees of ectropion of the upper lid if it is too distal. And I'm going to explain that in a minute in the next slide. If it is too proximal, the fulcrum effect of the sling will be diminished. Normal distance is usually approximately 3 millimeters. Where the spore bells phenomenon, the lift should be just a little above the visual axis. Example in CPEO cases, chronic progressive external ophthalmoplegia cases. So remember your frost suture to take care of post-op lagophthalmos, like she mentioned earlier on. So I mentioned distal and proximal. So from here, this is the lid margin. So this area is the distal end, and towards here is the proximal. So when we say that if you put your sling too close to the edge, to the lid, it's going to cause evasion, some degree of ectropion. But if you take it too backwards, the fulcrum effect that will pull the lid up will be diminished. So you just come to about around 3 millimeters, so you can have a maximal effect of the pull, which is what we desire. Now look at this section. I show it right here. So you can see the lid margin from here to here, could be around 7 millimeters, 8 millimeters of tarsal, plate right there. Distal, proximal, 3 millimeters, somewhere in between, and you are done. Let's go. Lagophthalmos, prolong the use of frost, suture. If you still have like much of the lagophthalmos after a few days, tape the lid at night, then use the bubble shield moisture chamber. Place it over the eye for protection in addition to generous ointment. So anesthesia, she has mentioned it. It's either general anesthesia or local anesthesia, which is preferred for adults. That's the volume to use, thereabout. You can do sensory regional blocks, depending on what you have there. So I'm just going to show an animated video right here of Frontalis sling. It also has a resection part of it, but I'll go to the part that has for the sake of time.
During a frontalis suspension procedure, the eye surgeon makes a series of small openings in the brow and in the eyelid. Then the surgeon places a special material through those incisions and uses it to connect the eyelid to the brow. Once your child has fully healed, he or she will learn to lift the eyelid by using the brow muscle.
So that's it. So like I mentioned earlier on, should always evert. She mentioned it earlier on that you should always evert to look so that you will not pass your needle through and through it could happen. No matter how experienced you are, you must always make sure you evade your lead as you pass your sling to avoid corneal abrasion and foreign body sensations later on. Always protect the globe with lead guard or plastic globe protector, and then do some lubrications. So these are some pictures. This is a pre-op case, was complete ptosis. He had a chin lift and head tilt. So you can see first day post-op. I think that's good enough. Okay. Another case of congenital ptosis in a young lady of like about maybe 20 plus or thereabout. You can see. How do we know it is congenital ptosis? She looks up here and then looks down. This goes, the normal eyelid goes right down compared to the ptotic one because of the tethered nature of the muscle infiltrations and all of that. So it's not going all the way down, it's not relaxed. So that's congenital. So we now talk about adjusting while on table. A series of pictures here will show how you do the adjustment. Adjust the lid height on the table. It is easier when the surgery is done under local anesthesia for the adults, but for the child, you just aim at putting it at the upper limbus. When the anesthesia is good enough, because when the anesthesia, the GA is not good enough for the child, the eye will tilt upwards. So you tell, at that point in time, you tell the anesthetist to make it deeper so that the eyes will not go upwards. Then you'll be able to keep it at where you think will be normal for the child. So this is a second picture. Some adjustments were being done here. You can see, but it's not yet, compared to this other side. So you see, keep adjusting. Now you can see the two arms of the sling, the one on the right and the one on the left. What you do is to get the contour. If the contour this way is not high enough, you pull the sling on that side to make it high enough to meet up with the contour that you want to, because you always want to compare it to the other side. And then if the contour on this side is not high enough, you then pull on the sling on this other side. But if it's just the height that you want to adjust, you pull the two at once. It will lift up the eye. So that's it here. You can see. That's it. It's almost at the point that we think it's okay. That was the final thing. Now, second day post-op, we can see the frost. You can see the marks left by the frost sutures to show you that it is the first day post-op. Because after the first day, this will disappear. So this is the first day post-op. Another case here that was done. This is the first day post-op. You can still see the stitches here. Look, there's a dimmer here showing that it's the first day post-op. Now, 1 month after, see the eyes right there. You can see a little scar here. After like a month or two, the scar will disappear. But you can see that that's a very good correction there. This is another one, post-op, 1 week post-op. Now you can see that one might have issues with the skin crease. You may not always get it right, but it's manageable. This is another case here. First day post-op. This is another case here. This is under correction. And what you do is you wait for the patient. If it's under correction, wait for the patient. Ask the patient, what do you want? Do you want us to go back and do a second surgery? Or do you want it like that? In most cases, because it is better than what they came in with, they'll say, oh, just leave it like this. They're just too happy to go with it. That's one thing with under correction. But if it is over correction, even you, the surgeon, you will know that you should do something about it. Okay, so this is another one here. This is an adult, about 32 years old. So now this is a poll question here. If you had to have complications in ptosis surgery, which of the two would you prefer? Is it over correction or under correction? choose one. We give you like 15 seconds. Wow. Wow. Is the fear of overcorrection is the beginning of wisdom. Okay. All right. So let's go on. This is another undercorrection. But the patient was very, very happy. If she wouldn't even allow anybody to come close to it. So we decided to look at the cases we've done. We started doing these cases since 2010, but we decided to take 2015 to 2018, a 3-year study, retrospective study to evaluate what we've been doing. It's not yet published. Age range 1 to 60. You saw like about 107 patients, but 78 met the criteria. 7 males, 21 females, 35 eyes, 7 bilateral, 71 unilateral. We used the Fox pentagon approach. Congenital ptosis was the commonest that we did, almost 70%. Traumatic ptosis was the least, only about 3 cases there. So, and the early complications were lead edema, lagophthalmos, which after a while, the eye would adjust and everything would just turn out right. And most common delayed complication was just a mild droop, like you're going to see in one case as we go down. Now, this case, this was one of my first cases around 2009 or 2010. That's like about 11 years ago. You can see here that this young man has some droop here, but then the visual axis is still right there, and it doesn't have any head tilt. The young man likes it like that. If he applies his frontalis a little bit more, this goes up a little bit more. So it doesn't bother because that's okay with him. So that's like about 11 years. You might see keep it like this for the next 10 years or more, or even more. So complications, just mild droop. Now this is a case that had a plexiform neurofibromatosis. This is post-op. Now pre-op, if you saw this chap, the whole of this, the lead was up like twice or thrice what you are seeing here. It's after surgery that it came down to almost the same lead length like this. So what this one needs now is just to do a secondary lift with ptosis sling. Now this one had trauma. This is 2 years post RTA with foreign body granuloma. Now the granuloma did not show up much pre-op when we were assessing her. So we decided to do this sling. But immediately post-op, we saw this coming up like this. And then we could really feel the granuloma right there. So, but the correction was quite good. But if she wants us to still go ahead, we can just do a little bit of, after taking out this granuloma, do a little bit of blepharoplasty, which will look good. And it's the case of blepharophimosis. One of the surgeries you do, because there's still some further surgery we need to do for this, but initially, just to get the visual axis clear, you have to do this just to get the chap going. All right. So other complications could be contour malalignment, exacerbation of pre-existing tear deficiency. So you have to apply a lot of ointment and all of that. So this is an example of the complications that could occur if the Bell's phenomena is bad. Possible complications again, we can have conjunctival prolapse. We have mentioned lagophthalmos already. So you inform the parents and the patients pre-op what to do. And then you also have to do a temporal protection, which is quite needful. Late granulomatous inflammatory reactions can occur. Abscess with possible extrusion of buried stump of sling. Not exposure can lead to not exposure. You can have migration of the sling. You could have mild droop of the lead over some years. All right, this is, well, for sling surgeries, it might not be this typical, but for resections, you could actually have had a patient that came in from Kano and both eyes, somebody tried to intervene and came up with something like this. I was afraid when I saw it, but we did something and the young man was okay. So it's good for one to know what you are going in for than to go and do a thing like this. So to minimize infections and inflammatory reactions, especially if one is introducing foreign materials into the tissue, you have to regate the operation site, avoid cilia or any foreign material introduction to the operation site, and then treat with appropriate antibiotics. It might be necessary to remove sling material except fascia, which is taken from the body. Then you can also, I mentioned earlier that you could have issues with skin crease, alignment with the other eye. But that is usually the least of the patient's, problem. But you can still try to see what you can do, because you are putting a sling, and the tendency is that as you pull the sling, it just bunches up the skin of the upper lid. So you cannot really say this is the skin crease. Everything just throws up itself at you. So now this is a case that immediately I think of ptosis surgery. It makes me happy because you don't want to have an overcorrection. If it's too overcorrected, you could run into problems. If you don't have the materials to use to adjust, the lid back to the normal position. So we did this case, this was resection, not sling surgery. I just brought this. I've not had any case of overcorrection for sling surgeries, but I brought this case in the case of resection, levator resection, so that we can see what overcorrection can, the kind of nightmare that you can have out of having a thing like this. When I saw her, it didn't look like this the first 2 days, but like the third day, the thing overshot, and I looked at it. My heart sank. I must say. So I told her we need to take you back to the theater, and she agreed. And we went, and good enough, I had left a little stump of the levator that I had, severed off, and I went to remove the stitches carefully, and now put, my stitches just at the edge, of the levator, and then attached it to the tarsal plate. And the next 1 or 2 days, everything was, because right there on the table, we saw that the correction had taken place, but a few days later, we were happy with what we saw. And this is what she looks like. Just with a little touch of, what ladies do, and she's just like that. And she told me that I can put this picture up. So you want to ask me, did you take any consent? She wants the picture to be up anywhere I present. So that's how it could look like, Pre-op, the first surgery was overcorrected. Second surgery is right here, what you are seeing here. So it could be quite rewarding. Thank you. See, in this era of free Wi-Fi, see, a lot of people love Wi-Fi, but there are also free books. They have knocked down the door to the free Wi-Fi, but there's nobody right there. Let's do a lot of reading of the free ebooks. Thank you for listening, and God bless us. You might want to ask your questions in the chat area so that we can put our heads together. Thank you very much.
Yes, you. Mm-hmm.
Can we have questions, please? Ask questions, type it in.
Some are typing in the chat box.
Yeah.
Thank you. How long do you leave your first suture? How long do you leave your first suture?
Oh, how long do we leave our frost sutures?
Sure.
Oh, we take it up the next day. It's just to take care of the period that the eye is still under anesthesia. and it's not closing well. So the next day, usually the effect of the anesthesia would have worn off completely. And we are sure that the patient would be able to close the eye, of course, with a lot of ointment here and there. As you can see, the chap that has had surgery for over 10 years, you could see he had no corneal issues. So people get worried that if they put this sling, it could cause corneal problems. No, it's not like that. Especially if the person has good bells, no palsy. You discuss these things with the patients, with the parents and all of that, so that when they wake up in the night and enter the child's room and see the eye like open, they will not run out. So discuss with them. Yes, for infants too. We remove it the next day.
Silicone is available. Silicone is very available. Suture, get a bond.
Well, it is what you are comfortable. You say what would guide one on the choice of either Fox, Pentagon, or Crawford. It is what you are comfortable with. I'm comfortable with Pentagon, and I've had good results over the years. So anybody that does Crawford, if you have good results, I mean, why not? Do what, bottom line, do what you are comfortable with. So how long do you wait before opting for a second corrective surgery? Some people wait for 2 weeks. Some people, but I think it would be, if you wait a few days until edema goes slightly down, because you may never know, like this lady that had overcorrection, the first day post-op, the eye was actually looked undercorrected. I didn't put that picture. It looked undercorrected, so I was happy. But it was 2, 3, 4, 5 days later, the eye just shut up like that, So just rushing in the first 2 days, you may go and do more damage. Just give it some time. Even if it's 1 week or 10 days, the tissues will not have healed completely. You can still go lift up the tissues little by little, go down to the levator, then remove the stitches and reattach. So don't be in a hurry to go and cause more problems. Is it advisable to do eyes at the sitting? We have done it. This is an external kind of surgery, so you don't really need to worry. If it's maybe cataract, you have been advised not to do both eyes in case you have problems with infection. But this is out there. It's even good for you to do so that the symmetry can be, really there. Is there any slacking of materials leading to undercorrection? Yes, there is. I showed that guy we did 10 years ago. It wasn't like that when we did it. So the thing now slacked, but it's still above the visual axis. A 3-month-old has ptosis. I would want to do something about it because amblyopia is more difficult to treat than trying to wait for all of that. How long is the Fox Pentagon sling left? It's supposed to be there for life. You say, why did you choose a resection for that case that was overcorrected?
Oh,
I only brought that one because I said I've not had any case of sling that had overcorrection. I only brought it to show that it could really be terrible, especially in resection cases. It could really be terrible. But for sling cases, I mean, overcorrection is not really that terrible. You can always go open up the pocket, bring out your sling, adjust it a little bit, and look at it and put it back. That's fantastic. But for a resection, especially if you had cut off much of the levator, you may need to look for stout, sclera or Gore-Tex, whatever, something that you can, as a spacer that you put in between your upper tarsus and the remaining levator. It can be quite funny. Dr. Allen, do you want to say something?
So I saw a question. Somebody is asking a bit again about, can you share with us your experience with contralateral eye in a case of correction for unilateral surgery? Herring's law on my mind. That's where your pre-op evaluation comes into play. You should be able to anticipate that, and that's what your evaluation should help you to anticipate. So that means you wouldn't want to, normally when you're doing a ptosis sling for a child, you want to put your upper lid just at the level of the upper limbus or slightly less than the upper limbus. If you notice that preoperatively, the evaluation showed that there was likely to be a droop there. Well, in theory, I've had to read about that, but I've actually not experienced that. Dr. Akan, I don't know that you've experienced that when you had to manually lift the lid and you notice that the other eye drooped, because that should expect you to anticipate a droop because of Herring's law. I've actually, the books talk about it, but actually in practice, I've actually not.
Not actually, in all the cases you have done, you have really run into.
You know, and somebody said, I think Dr. Baloguma, about doing the surgery when the child's mother is on vacation, that she finds herself. I think that's very wise, you know, and not only for this kind of surgery, I guess for any surgeries that you do for a child, as much as possible, if you want to make it when the mother is on vacation, so that she can be there for the post-op care. I think that's a nice tip there. And somebody said, ask them, chromic catgut being an absorbable material, will it not lead to recurrence after absorption? And that, in addition to somebody asking, supposing you do not have silicone available, what else do you want? The truth of the matter, that's one advantage. Silicone is very, very available. However, in some cases, for example, for some children, very young children, we've had to use ethibond, and then you don't even use the Fox pentagon, you just use a triangle, you know, 2 sutures at the lid, 1 at the apex, just to lift the lid till you can get something better, till you can get something more definitive. So when you are thinking amblyopia is going to be a very serious issue, you can use ethibond. But I must let you know that silicone is actually, that's one of the advantages. Silicone is very available. Chromic catgut, I've actually not used it and I've not seen it used, but I do know that it's been mentioned. But we also understand that many of these synthetics, they learn their place to be used when you're thinking of a procedure you have to revisit. For example, I gave an example. Typical procedure is BPES, okay? When you know that a BPES, you might have to do a ptosis first, and you go back and deal with the epicanthus and the telecanthus and come back and deal with the ptosis, except you want to do everything instead of a stage surgery as a single procedure. When you know that the ptosis is quite severe and you are dealing with, there's a risk of amblyopia at that point in time, and the midface is not developed enough for you to repair the telecanthus and the epicanthus. You know, so that's why we can use all these other materials, but actually they are not as long-term as silicone or facial Lata. In theory, they've actually spoken about silicone being fraught with a lot of recurrence. But I'm sure Dr. Akan will tell you, you have patients that are, you know, almost 10 years post-op, and you don't have even anything more than 1 millimeter droop using silicone, whereas you would expect in theory that, you know, they would have had a lot more recurrence than that. But that has really not been the experience that we have seen. And for now, it seems to be achieving what we are looking for, because it's still difficult for us to be able to get good stripper for facial Lata or banked facial Lata, as the case may be. Dr. Akan.
You mean in case of fascia Lata?
No, I'm talking about having recurrence with the silicone that you have so far, that we've not really had it.
I've not really had all the dozens of cases.
Not really had it so much. Yeah.
It has not been that much for one to look for another alternative. I think for me, I think it's still the best for now.
We don't have, for now, we don't have access to a facial stripper, you know, and silicone has been quite okay for us, you know, and it's relatively available, and it's quite inexpensive, especially for a resource challenge setting as many of us are practicing right now.
There's a question here that says, how do you guide against implant extrusion? For me, once you make a good pocket and tuck it in properly, some people would even want to put a stitch and anchor it somewhere. Whichever one, the important thing is that you must make a good enough pocket, tuck it in properly, and then close it. Put about 2 or 3 stitches, make it look neat. I've never had any case coming back to come and be presenting my sling to me. Like somebody will remove sling from the nose and come and say, "Doctor, I saw this thing coming out." No, I don't need the sling. I want the sling to be in the patient's tissue. So that's good. Just have a good enough pocket, and bury it very well. It will not come out.
We have some questions on Q&A.
Who are the ideal candidates for sling, looking at the various etiologies of congenital ptosis? Hello? Can you hear me, please?
Me?
Yes,
I can hear you.
Who are the ideal candidates for sling? You must, many times, the patient, you must be able to balance the fact that some patients will have symmetry in primary gaze, or you may not be able to achieve symmetry at any gaze other than primary gaze. That's when you do a sling. However, you want to do for other forms of ptosis, you want to do, depending on the extent of the levator function, you want to do a levator resection. The bottom line is the levator function has to be poor. If the levator function is better than poor, there are other surgeries that you will do, levator resection and the rest or whatever, levator aponeurosis attachment, depends. It's your evaluation that determines it. So if you think that it's the aponeurosis dehiscence, you go and repair the aponeurosis. If you think that levator function is moderate to poor to good, you don't do a levator resection. It's only when the levator function is poor. What the challenge is that actually, in some people actually with a poor levator function will still tell you that they're not ready to deal with having the child having asymmetry in anything other than primary gaze, and will still attempt to do a levator resection for the child. In fact, there's a lot of arguments about that. But by and large, the ideal patient is the patient who has a poor levator function, because you know that at that point, a resection will not achieve much. You have the patient come with levator function of 1 millimeter, 2 millimeter.
What do you do with that?
You have to do something to augment it. You can't strengthen the muscle. The muscle is infiltrated by fat. You have to do something to bypass the muscle, and that's where your counseling of the patient comes in, and to have them what I call it righteous expectations for the surgery, and to avoid the risk of amblyopia especially for children.
The Q&A chat, we have questions.
What are the ID candidates? What do you get against? Is that fixed, or do you take same height as expected in the unaffected? Thank you very much. Dr. Akan, do you take your 3 mm mark? Is that fixed, or do you take the same height as an unaffected lead? Bottom line is that you don't want to go as close to the lead marginal. Hello, are you with me?
Yeah.
Your 3 mm, can you answer that question? Usually we're able to, by and large, maintain that 3 mm mark many times puts you almost at the same level with the unaffected lead. What do you say?
Yes, that's true. Just not 3 to 4 mm, anything in between that. Because if you go too backwards, the lifting effect, of your sling might be compromised. If you go too forward, you may tend to be lifting up the lead where the patient, especially if there's an underlying, if it was maybe a traumatic case and the conjunctiva is tethered somewhere, and any lift of the lead, you just see a red conjunctiva showing forth, announcing itself. And you don't want to have such tiny lifts, on the lead. So you just go a little bit backwards so that the lead itself will still be well opposed, to the globe. That's the whole idea. You want to take it at 4 millimeters and you see that you have that effect, but don't go beyond 4 millimeters. If you go too backwards, that doesn't affect the crease.
And one thing I have found operating on the lead is very nice to factor in regional anesthesia for adults, because you don't want, when you do infiltration, as much as when you want to do anything that will avoid infiltration directly, because you end up causing edema to your tissues, and when you are measuring and taking your language, it's a bit difficult for you. So if you can do regional anesthesia so that you can anesthetize away from where you are working and avoid, so any edema that comes is edema post-trauma, but not from your infiltration or from your anesthesia, it does come in quite helpful for this.
That's good. I think we've just about
superior orbital rim fracture and loss of frontalis action. What do you do, please? Complete ptosis, superior orbital rim fracture and loss of frontalis action.
complete ptosis. Well, I've not actually had a case like this, you know, but I guess if it comes, I will, cross the bridge. By the time I think about it, I should be able to come up with something. So I've not really actually had a case like this. Excuse me. What's your experience?
Think for Dr. Akan. Can you remember that guy that came and had gone from northeast to northwest and all that? And we finally ended up putting a sling and putting a shell. I think by and large, let's look at the individual. I want to assume that the ocular status is intact. I want to assume that the fracture of the orbital rim did not affect any other thing like brain injury, CSF leakage, or whatever. That is just soft tissue injury. I want to assume that the floor is okay, the eye is okay. Complete ptosis with superior orbital rim fracture. So am I thinking that the ptosis is from a traumatic third nerve palsy? I would observe. What if there's anything in the eye, we'll manage it accordingly. I would observe and watch what kind of resolution we have. Let me be, of course, I'm going to assume that the evaluation has proven that it is a traumatic ptosis from the trauma. And so there is the third nerve pulse is not from anything more proximal, but from the trauma distally there. I would observe the patient. I will not be in a hurry to do a procedure there. And if it's an adult, there's no risk, there's no fear of amblyopia. Let me see and I will observe him serially and see whether there's any form of resolution and ptosis is resolving. And if I don't see that, then I might have to intervene. It's very likely, if this is the situation, it's very likely that the levator function may be severely compromised. I would likely offer a sling, you know, and with, of course, a lot of counseling for the patient. It's not likely that this patient might be a child. However, as a child, the issues with amblyopia will have to come into fore because I want to think of how to clear the visual axis as soon as possible. So whatever I might do, I might want to ensure I get the eye open as soon as possible. Maybe even if it's a suture, even if it's a native bond or something, and maintain that. But by and large, usually, like we said, for trauma, you want to observe and see whether there's any resolution as it might occur in many trauma cases, and see what is left after that, and I will repair. I think that's what I would like to do.
Dr. Baturian, please, can you unmute Dr. Bolanle Balogun? In her own experience, maybe she may want to drop 1 or 2 words as to how she manages, you know.
Hello.
Thank you, ma. Dr. Bolanle Balogun is a very senior oculoplastic surgeon. Thank you, ma, for your presence. Thank you so much.
Thank you so much. This is really interesting. I like this initiative, and we've also learned a lot. I've had a patient like that who had that injury, and I kept thinking, what do I do? Because indication for tarsal sling procedure is if you have complete ptosis. But this patient does not have frontalis action, so a sling will not work. We have to note that. So in that patient, we may then have to explore other procedures like the levator resection, in which case we've now had to leave that indication of complete ptosis sling. Thank you.
That's true. You're welcome.
Thank you.
Thank you, ma'am.
Most post-traumatic cases of ptosis, if you can explore and reattach, is always better than trying to use sling. But the issue is always that if the trauma had taken place many years earlier, the level of fibrosis and all of that, it doesn't give you room to really do much. But if it's a fresh thing, you can always try to see how to reattach, get the frontal, the levator, and attach it, to the tarsal plate. That's good.
Thank you very much.
Thank you. Thank you.
Okay.
Thank you, participants.
Thank you.
Thank you, panelists.
Thank you.
Thank you, Dr. Bature.
Thank you, Dr. Bature.
Thank you, the CMD of Eye Center that allowed Bature to be part of this, to bridge the gap. So.
Thank you so much.
Thank you, sir. Thank you for coming. We appreciate your presence and your time and the knowledge you have impacted on us. Thank you so much. We'll share the link for the video on YouTube very soon.
Okay, okay.
Thanks.
You're welcome.
Thank you.